Hello, everyone, and welcome to today's webinar. This session is proudly presented by Merck Canada, a sponsor of the CVMA Business Management Program and a CVMA Platinum Level corporate sponsor. We're delighted to have you with us for the next hour. To ensure the best experience for everyone, please keep your video and audio muted. This will help maintain a strong connection throughout this session. It's now my pleasure to introduce Dr. Karen Prost, Companion Animal Veterinary Services and National Technical Lead Biologist at Merck Canada. Over to you, Karen.
Thank you, Janie, and welcome everyone. I'm honored to introduce Dr. Margie Scherk, the expert in feline medicine, a leader in the field who truly needs no introduction, but for anyone who isn't familiar with her work, here is her background. Dr. Scherk graduated in 1982 and went on to open one of the first dedicated cat clinics in North America in 1986, located in Vancouver, Canada. She became a board-certified feline specialist the very first year the specialty was offered. An accomplished author and editor, Dr. Scherk has published several clinical trials and contributed to numerous books and book chapters. She co-edited the Journal of Feline Medicine and Surgery for 23 years, and is a frequent international speaker who also enjoys teaching in online settings. Dr. Scherk has served extensively with the American Association of Feline Practitioners and other veterinary organizations. Her professional interests span all things feline, with a focus on analgesia, feline nephrology, the unique characteristics of the feline digestive system, advocating for an end to declawing, and promoting more positive, stress-free interactions with cats. I will now leave the floor to Dr. Scherk to discuss all things FeLV and lift the fog surrounding this disease.
Thank you so much. Come on, Ontario. Let's get this. Last province that hasn't banned declawing. Anyway, that's not my soapbox today. Today I'm going to be talking. I've been asked very kindly by Merck to speak to. Around FeLV, because certainly it can be a frustrating thing, and it is also there have been some changes which are really very cool. Okay, so the question I have for you that I'm hoping you will ponder more at the end of this is FeLV seeing you without you seeing it. So I'm going to give you a case here. This is a cat named Dolores, and she lived with a friend of mine. She'd been indoor only since kittenhood, and I don't know whether that was, as Scott Weiss likes to say, aspirationally indoors or truly never paws on grass. I don't know, but she was indoors only, spayed female, domestic medium hair. She was retrovirus negative when she'd been tested as a kitten. I don't think we'd had a reason to test her in the interim because this is previous way of thinking. She had no housemates. She was in lovely condition and in very good health. I just want to get rid of myself there. I do not need to be seeing myself. Get out of there. So she was, when she was 14, you can see she's not looking too well. And this isn't just the 14-year-old cat with CKD, but it could be. She had a vague illness, and on exam, there was pallor. She had CBC biochemistries, urinalysis, and I believe her blood pressure was normal too, because that's part of my minimum database. And she had a non-regenerative anemia. Okay, so we tested her for FeLV, and she was positive, and we confirmed it with IFA at that time, and she definitely was FeLV positive, yet had not been as a kitten, and had not been outside and had no housemates. So what I'm going to go over here now is a whole lot of stuff here that we always need to know, the prevalence, who's at risk, because when you look at prevalence, there's a lot of good questions to ask in that, the outcomes of exposure, etc. We'll just go through these as we, I am trying to get rid of annoying little pop-ups here, but that's maybe not going to happen. So let's start with prevalence. So from a number of studies, if you put them all on a map, and that was fun, let me tell you, you can see that, in Canada, we're about 3.4, in the US, It's 2.3. Mexico, it's higher. You look in South America, and it's in Brazil specifically, and in this study it was 22.3. And then there's a whole lot of overlap in Europe, and Australia is not very high, and in Indonesia it's a bit higher. The point is that the prevalence depends on the population who's being tested and what was tested for. So you really can't compare these things, and that becomes problematic. In healthy cats, FeLV infection rates are between 1% and 8% in Europe and in the United States. However, if from those two regions only sick cats are included, the FeLV prevalence was as high as 38%. So you can see how whether somebody brings their cat in for routine health care and they're being tested, or they only bring them in when they're sick, etc., plays a role. So that means cultural differences, financial differences, all kinds of socioeconomic differences, I guess is the correct term for all of that. In a large pan-European study that I'll show you a bit more about by Studer, where 6,005 cats, sick animals were 2.43 times more likely to be FeLV positive than healthy cats. And more recently, in Brazil, the prevalence is 11.5 to 38.5% when combining ELISA and when using ELISA and or IFA, but it's 47% when you detect proviral DNA by PCR. So that's a heck of a huge difference. Lee Stockdale's trying to get in. Okay, so here, just again, not to belabor the point, but you can see here, this is looking specifically at antigen. So this is then the FeLV antigen prevalence. You can see through the different regions that in general, what you'll see is that in the Caribbean, Latin America, Southern Europe, and then the Middle East and Africa, it's quite a bit higher than in the Asia Pacific. So thinking Japan and Japan, South Korea, Northern Europe, and North America. And here are the number of cats that were tested. This is this pan-European study. I'm not going to go over all the schmoz here. It was prospective 32 European countries. They were looking for viremia. In other words, they were looking for viral RNA by real-time PCR. So they were looking as well. They were looking for no, they weren't looking for antigenemia. And here you can see again what I said earlier, that in the warmer, more countries, the levels are quite a bit higher. The prevalence is quite a bit higher when using those two types of tests. Then when, so yes, this was antigenemia. Then when using, then in the northern cooler countries. Again, looking at the Studer thing, this is, I promise you the last slide on worldwide Stufihu. You've got some surprise, some higher numbers here, and Ireland kind of stands out because it's not really in the south, but these other places that are in North Poland, but you can see some quite wide ranges of results, and generally in Europe it's 2.3. Now let's get back to Canada, which is what we should be talking about all along. And if you're not familiar with CAPC, I do recommend that you check them out. That's Companion Animal Parasite Council. And they have a section for Canada as well as the US whenever you look at their data. However, don't forget our own very outstanding Canadian data collection set. So what you'll see here is lower levels in BC, very low in the Northwest Territories and the Yukon, and virtually not at all in Nunavut, but it may just not be being tested there. In fact, when we look at the rest of Canada, Quebec is a particular hotbed for, which isn't showing in this data set, but it has in others that Susan Little and Dorothy Beansley and a few other people have looked at. And that Quebec, for some reason, is very high in both FIV and FeLV, and some of the maritime provinces as well. So this was just to date when I looked at this a couple of weeks ago, and that so it's 2.4%. So exactly what we said before. Okay, enough prevalence. If you're not bored yet, you should be, but let's get back to this. So who can be infected? Essentially any domestic or wild cat. And in vitro, so in test tubes and on plates, you can infect non-felid cell lines, but there are no reports of natural transmission of FeLV to non-felids. And in fact, I was part of one of those studies where at the AFP in, can't remember where it was, one year, they asked for volunteers to be tested, both for FeLV as well as for feline syncytium forming virus, or anyways, and there were 0 cases despite the presumably high risk that we're at as veterinarians. Is there a breed susceptibility? No. The risk factor is, of course, and I've taken this from Little, which I will tell you is from the retrovirus guidelines, management guidelines. So that means I cut off the FIV section. But here, you can certainly see increasing age somewhat, being male, being sexually intact, no surprise there. Those are similar to with FIV, although it's higher for age there. Outdoor access, yes. Close contact with infected cats. So this is really important when we talk about social activities. Intercat aggression, the risk factors with they may cause or be a result of these illnesses, and then being born to an infected queen. Like FIV, being born to an infected queen, the whole litter doesn't have to become infected. It is an individual infection. Now let's just look here at age distribution. And what I'd like to point out here is this very high number, the highest number between 13 and 52 weeks of age. And that's really important when we talk about prevention. But you can see that we do see it here too. And this is probably whether they're being infected at this time or whether it's showing up at this time, we don't know. So the outcomes of exposure, this is where it gets really fun and funky and is different from how it was when, perhaps it's different from how it was when I went to school. Oops. So yay, everybody's seen this image before. This is, shows that FeLV it's a single-stranded RNA virus. Each virus particle has 2 identical strains of RNA. And to detect the viral RNA genome, there's a reverse transcriptase polymerase chain reaction, or PCR is needed. The virus contains enzymes which include the reverse transcriptase. The reverse transcriptase integrase and protease, and the reverse transcriptase converts the viral RNA into DNA once the virus has entered the host cell's RNA, or host cell rather. Okay, so this is what's important here is that the envelope is a lipid bilayer. It makes it unstable in the environment. Yay. We tend to test in the point of cares, the ones we're doing in the clinic, those are all looking for the P27, this capsid protein here. And we can also test for glycoprotein GP70. Vaccine strategies aim to target there for the GP70 because of its critical role in immunity. So pathogenesis, cats typically acquire FeLV through via the oronasal route. So grooming another cat, potentially if they've got cuts in their mouth, they could also become infected through bite wounds. Being in the litter, anything that's wet, moist, they can be exposed to. So after oral nasal exposure, then you get local lymphoid tissues are infected. It spreads via the monocytes and lymphocytes. That's the primary viremia to the periphery, plus or minus the bone marrow. And then following bone marrow infection, secondary viremia may result in FeLV containing white cells and platelets, which circulate. And at that that point, we can detect it with IFA. Okay, so remember, IFA is looking at the white cells. Here we're looking at looking for the capsid protein. So I'm just going to read this to you because this is, I think, really important to understand. Once FeLV particles have attached to, okay, right here, and fused with the host cell, the viral RNA is freed and converted into viral DNA, RNA reverse transcriptase DNA. And then this DNA is integrated into the host genomic DNA with the help of an integrase. And at this point, it's called proviral DNA, and it can be detected using proviral DNA PCR. When the cell is activated, then a new viral genomic RNA and messenger RNA are generated through transcription, and proteins are produced through translation and processing and assembled at the host cell membrane to build new viral particles through assembly. These are shed into the blood and saliva, so budding, but also, in addition to viral particles, free soluble P27, remember that's this stuff in here, antigen, is found in the blood. So just a quick reminder on that. So you got all these different steps. And it helps when you remember that you've put in arrows. Great. Now, the 4 clinical courses. Most cats are going to have about a third of cats are going to have abortive infections, and they're effectively eliminated by an immune response prior to the virus successfully infecting the actively dividing cells. And this prevents the integration of viral genes into the host chromosomes. We also have, and easily another third are regressive infections, and they're the ones that we probably aren't even aware of. Then there's progressive; those are the ones that we're looking at, and focal. It's rare. All right, so here again, just looking at prevalence by stage. In Italy, Portugal, Germany, and France, total prevalence here in the first column. You can see abortive infections, which is great. That's what we want. You've got, and this is percent of the total here, so about a third, and here, about a third throughout. Then regressive, which is hopefully it doesn't transform back into the progressive form, and you can see here different levels. Then we've got the progressive, which are the really bad ones, and then focal, we just don't really know about. So in an example of a multi-cat household with high infectious pressure by young cats, so young cats, there's a lot of stress going on in a multi-cat household. Most cats will abort infection unless under stress or poor nutrition, suffering from comorbidities. 30 to 40% develop regressive, 30 to 40% develop progressive infection. But in other typical situations where there's less stress, the rate of progressive infection will be much lower, okay? So therefore, although guidelines, when you see anything in these colors, it's from the AFP, Susan Little AFP retrovirus guidelines from 2020. Although guidelines for prevention of infection have been available for decades, there remains a need to improve adherence to testing and vaccination recommendations. So the regressively infected cats, these are the, keep your eyes on them. They have low levels of antigen and as well as proviral DNA, right? Because they are making the antigen, they are making some proviral DNA, but it's not enough to tip the scales. If their immune status changes, the cat's ability to suppress the virus may be affected, resulting in changes in the amount of antigen or DNA. These may increase or decrease, making them more or less detectable, resulting in inconsistent and discordant results. Don't we all hate those? So it can be hard to definitively determine the cat's true infection status in a regressively infected cat. So you can't tell if they've aborted it, if they've never been exposed, if they were exposed and aborted it, or if they're regressively infected. Now, progressively infected cats generally have high levels of antigen and proviral DNA in circulation, so you can use the point of care to check for the P27 antigen and or lab-based PCR tests. The testing status of progressively infected cats is unlikely to change over time, and this makes the diagnosis relatively uncomplicated. They may or may not be sick at the time of testing, and they certainly should not be euthanized based on their FeLV status. The illness depends on the subtype of FeLV. I'll show you one slide on that. Don't worry, not going into that. Cats who are testing positive by both P27 antigen and PCR initially may transition to a regressive infection pattern, usually within 16 weeks post-infection. So that's when you're scratching your head going, but I thought you were positive. Oh, no, you're negative. Well, you're somewhere, you're regressive, so you can go either way. Progressively infected cats will shed virus in saliva, hence biting, or grooming, nasal secretions, milk, urine, feces, and in utero. So here's that one slide. Promise you're not gonna, you can look at this later on your own. I'm going to say FeLV-A is most common, but each one has a different, presents with a different type of disease. So non-regenerative anemia is most likely C, but most of them have A+, and then if they have something else, it'll be A plus one of the others. Enough. Okay. Sorry, it was feline sarcoma virus that they checked us for as well. So progressive infections, FeLV infection occurs when FeLV infection is not contained early on, and there's inefficient or insufficient FeLV-specific immunity. They have a shorter survival time, and they succumb to, which is interesting because with FIV, it does not affect their lifespan. So that's another important thing to remember. So shorter survival time though with progressive infections, and they are at risk to succumbing to FeLV-associated diseases. We can detect a progressive infection within 1 week of exposure. Their viral RNA, so we're actually looking for FeLV in plasma via real-time reverse transcriptase PCR. Within 2 weeks of infection, we can detect proviral DNA. That's where we're looking for it within the nucleus of the cell itself. And that's the if after 30 days or longer, FeLV antigen is found in the saliva and other secretions, and that's the point of care test. So that one only becomes positive 30 days or later. Now, the regressively infected cats, as I said just a couple of slides back, may also show this pattern with their viral load decreasing to undetectable levels over time. So what sort of diseases do we see in the FeLV-positive cats? What are the outcomes of infection? Directly related to FeLV infection, you can get bone marrow suppression of any one of these lines of cells or all of them. You can get lymphoma, leukemia, other neoplasia, neurological, and it tends to be peripheral disease, more common than central nervous system disease, immune-mediated uveitis or erosive polyarthritis. So immune-mediated uveitis, you might be thinking FIP, erosive polyarthritis, you may be thinking Khaleesi virus, reproductive disorders, and I just listed fading kitten, but you get mummification, abortion, etc. So secondary to FeLV infection, so they're not directly related to FeLV, you get immunosuppression, which means then that you can get chronic or recurrent infectious diseases and inflammatory oral disease, which I really want to focus on briefly. Then, of course, they can also get diseases completely unrelated to FeLV that are common in cats regardless of their status. So CKD, if they're older, lower urinary tract diseases, diabetes, hyperthyroidism, et cetera, et cetera. I mentioned the mouse, and this is really important in a study that we published in 2014. I was involved with Matt Cornia. He was the primary author. We looked at and gave very specific, maybe some of you participated in this study, for which I thank you. We gave very specific examples, both verbal as well as pictorial, as to what was gingivitis, what was periodontitis, what was stomatitis. And what you can see here is that the FeLV We also looked at FIV as well, but FeLV seroprevalence with gingival stomatitis, you can see that about 5% of them have it. With periodontal disease, about 7%. With stomatitis, we're up at 10% or more. With other diseases, namely calculus, neoplasia, resorptive lesions, etc., 4%. And then orally healthy, of this whole group of cats that we looked at, and I'm sorry, I don't remember the total number, or where the results were. We didn't look at, we just analyzed data that you guys produced, 3%. So no oral disease grossly apparent. So this was essentially the control group, wasn't it then? So very clearly, cats with oral disease, the retrovirus status influences the care of cats with oral disease. And so it's not only super important to disinfect dental equipment, but we may also want to be testing all of these cats too. You're certainly justified for testing them, even if you were, even if the cat was otherwise healthy and had been tested when they were younger, because with this disease emerging and the pressure on the immune system, we may have now pushed somebody who had regressive infection, in other words, not detectable, to the level of, with a point of care test, to the level of showing disease. Now, this is a little bit busy, but I still really like it. This is from the ABC, oh, it actually isn't. This is from the Hoffman, Lehmann, and Hartmann, who published this around about the same time as they updated the ABCD guidelines, which I'll refer to frequently. That's the Advisory Board on Cat Diseases of Europe. And here you can see that weighing the scale. Here, if you've got a good immune response, you abort the infection. Your immune response outweighs the effect of the virus. Here you've got, with regressive infection or rare focal infection, the immune response is better, not so good here, but so there can be some changes, and we'll see proviral integration. And here we'll see sequestered viral integration. There may be transient viral replication, whereas here there's sequestered replication. With progressive disease, or when regressive disease is reactivated, the virus wins. And so there's no immune response. There's proviral integration, systemic viral replication. So here, this is showing the magnitude of the anti-FeLV immunity, the degree of provirus integration, the degree of virus replication, and the potential to induce FeLV-associated disease. And when it's shaded like this, it means it's variable within each category. You can't just give it a line. Oh, sorry. So that was the probability of either positive or negative status with the yellow. So which cats are at most risk for developing FeLV? Well, living with an infected cat, multi-cat households, outdoor cats, and kittens and young adult cats. It's most commonly from close social contact, saliva from infected cats. It's shed in the blood, urine, feces, nasal secretions, and milk, as I've already said, and then vertically to the queen, from the queens to the kittens, transplacentally during birth or through the milk. And when I say milk here, this is cat milk. We're not talking about cow's milk or anybody else's species milk. Sharing food and water dishes, using the same litter box, and mutual grooming. It can cause transmission, bite wounds, so that could be in a household or cat going outside, and blood transfusions. So it's really important with blood transfusions that we test for provirus via real-time PCR, reverse transcriptase PCR, and antigen as well. So that's the point of care test. But we don't want to just do a point of care when you're doing blood transfusions, because you won't pick up those who are regressively infected, and presumably the individual for whom you are giving the or to whom you're giving the blood is already immune compromised in some way, shape, or form. There is an important age-related risks. Kittens under 6 months of age have the highest risk for developing progressive infection. And as they become older, there is an age-related resistance. Because of this, we want to vaccinate all cats under 1 year of age, and then boost them at 1 year. And thereafter, we're going to do it for adults based on their risk of infection. So are they living with somebody who's FeLV positive? Are they going outside? Have they been bitten, etc.? So cumulative lifetime risk of exposure is actually higher, and I showed you that on that slide, which showed the age of age of positive FeLV cats, and the adults can be infected, or, you know, again, was it a regressive? We can't differentiate all that well. So high risk are those non-pedigree cats, intact males, outdoor or multi-cat environments, especially if there are 5 or more cats in the environment, from high prevalence areas, and unvaccinated, FeLV unvaccinated cats. So we really want to make sure that we get all these guys vaccinated and boosted. Life expectancy of an FeLV positive cat, once it's progressive, as I alluded to before, life expectancy is shorter. In a study looking at 800 FeLV positive cats by Julie Levy, published in 2006, with 7,000 matched controls. The median age of cats in the study was 2 years. For cats not euthanized near the time of diagnosis, this was a shelter and TNR group, trap, neuter, release group. The median survival time after diagnosis was 2.4 years for progressively infected cats, and 6.3 years for negative controls. So, you know, you're talking 8.3 years of age. Again, this is not a well cared for homed group of cats. Then in a German study published a few years later, they looked at 100 cats. The mean survival time of progressively infected cats was 312 days, so just under a year, significantly shorter than the uninfected cats, which was, you know, 2 years or whatever that works out to be. And so again, quite a bit shorter than what you would expect from a housed negative cat. This is where it gets really exciting. Well, first off, I think the whole idea of regressive infection is new since I graduated in the land before time, 1982, call out to OVC. But also also what was new or has changed since I was first taught about this disease was the fact that, you know, this age-related risk of infection. In a longitudinal study of 127 naturally infected cats and 127 FeLV negative cats over 4 years, this was done at Austin. It's called the Alive. I can't remember what it is. I've got it on another slide. Really neat shelter in Austin. Point of care and microtiter plate ELISA immunoabsorbent assays for P27 antigen, as well as real-time PCR for proviral DNA, was taken at intake in this shelter. Not many shelters can afford to do this. Based on the initial antigen concentration and PCR load, they were classified as either high positive or low positive. Okay, high positive or low positive. There was a significant difference in survival. The high positive cats had a median survival of 1.37 years from the time of enrollment. Didn't matter what age they came into the shelter, while most low positive cats were still alive, 93% survival, at the end of the 4-year study. So that means that the level of the survival may in fact be related to the level of the concentration of antigen and the load of PCR. Here you can see it. Yeah, it was Austin Pets Alive, and the universe, and then Julie Levy and let's see, Missy Beale works for IDEX, and Julie Levy is at the University of Florida in shelter medicine. So you can see quite a difference in the Kaplan-Meier survival curves. This is going out to 6.5 years now, past the 4-year level. High proviral load, 92 of them, 1.2 years, and low proviral load, 29, median survival not even reached. So here we're just looking not at the antigen, but looking at the PCR. So also from Julie, I adapted this from one of the slides at the ISCAID. If you're not aware of ISCAID, please, it's a good chance to become aware of it. International Society Companion Animal Infectious Diseases. It's a really cool group. Every 2 years they have a meeting. The next meeting is going to be in Dublin in 2026. So you can see here, this was all being run at IDEX. It was all being run at IDEX here using ELISA in clinic, quantitative real-time PCR at the lab, and then also doing, ELISA was being done, not in clinic, in the lab, and then point of care is done too. So what they suggested, or what they did was, she's recommended follow-up testing because this can provide additional important information. You want to screen using anticoagulated whole blood, better than serum or plasma. You want whole blood, and you're going to do your SNAP or your point of care in hospital. Then if they're positive, you do follow-up testing, doing quantitative PCR, and if they have high levels of copies, then they would be classified as high positive. If they have low levels of copies on PCR, then they're a low positive. And if they're negative, then they're going to do an additional test, the PET check, which is also an antigen test. Positive, if it's positive, then they're considered a low positive. If they're negative, it's considered uncertain. So you can see where some of this discordancy stuff is coming from. And this first became aware when this was, oh my gosh, I was part of a group that was asked to look at, I think there were 91 cats or something here, and they followed 6 months worth of tests using the SNAP on whole blood, SNAP on plasma, SNAP on serum. Okay, then they're doing the PET check on plasma at IDEX, PET check on serum at IDEX, PCR quantitative, and then immunofluorescence antibodies on slides looking at the white blood cells. And so they asked us, what do we do with this? So it's a 2-month-old kitten here. By here, she's 8 months of age. She's positive here, but she's negative here. She's positive here on plasma, but negative in all of these, negative in all of the serum, which is why we're saying use the whole blood. Then on plasma, she's a negative on 2 of them here, but positive on more than she was on the SNAP, and on serum, negative on all. So again, saying no serum, go whole blood. And then PCR negative, low positive and positive here at 4 months, but negative on IFA throughout it. So we're sitting here going, this does not compute. And there were some prime advisors there from Germany and Switzerland, Regina Hauptmann, Katrin Hauptmann and Regina Hoffmann-Lehmann, who were just going crazy because they spent their lives studying this, and this did not make sense. Okay, so how do we make the diagnosis then with all this? Okay, let's look. We've already started talking about discordant results, and then there's a concept of one and done, and this is really useful for shelters. Or with TNR, it's just probably not worth it even doing that though. So here on the left, I've got a quote from the AAFP guidelines chaired by Susan Little. Diagnosis of retroviral, so this is FeLV and FIV. The most important measure for the control of FeLV and FIV is identification and segregation of infected cats. AFP, now called FVMA or feline VMA, recommends screening all cats for infection at the time they are first acquired, prior to initial vaccination against FeLV or FIV in the countries where they still have the vaccine. I don't know if anybody does anymore. And following potential exposure to infected cats, or if clinical signs of illness, any illness, are displayed because of the concept of regression. And then from the ABV, or pardon me, not ABVP. Sorry, Mike. From the ABCD FELUC guidelines, because this is the European, and they've got a slightly different take on it. They're suggesting testing for FeLV-positive. So again, this is your point of care test. In all cats with unknown status, cats suspecting of having an FeLV infection for any reason, sick cats presented for veterinary examination, healthy cats prior to FeLV in vaccination, and cats with an unknown FeLV history. And finally, for detection of FeLV shedders, such as in a multi-cat environment. And prior to introducing the new cat you test into the environment. Okay, so routine or our day-to-day diagnosis would be looking at our P27 antigen, that antigen that's inside the virus, using point of care, and the lab can do microtiter ELISA, or the lab can repeat with a different point of care, or you can repeat with a different point of care if you get a positive. It's to confirm, whatever confirm means. Positive reflects antigenemia. And it's usually consistent with viremia, but not 100% of the time. If it's persistently positive, then you know you've got a progressively infected cats. But if it's transiently positive, if they're able to push that virus down, get their immune system happening, and they push it and they become regressive. Because cats may overcome viremia over a few weeks or months, healthy antigen positive cats should be retested. They should be negative by 12 or 16 weeks. When we look for PCR, provirus PCR, it detects the genome integrated proviral DNA, and it's positive in both progressively and regressively infected cats. Okay, so that one's going to tell you if somebody's regressively infected. They may have only a low level of proviral DNA, or they may have a high level, depending on what stage they're at, but they will have proviral DNA. RNA testing for like a true virus, it's not done routinely. It indicates viremia, and they become positive long before the P27 antigen becomes positive. So vaccination and maternal antibody do not interfere with FeLV-P27 antigen testing. So unlike with FIV, where it will, because you're looking at antibodies, we're actually looking at antigen. And this is one thing that I've always had to, I first became aware of when people were saying that the breeder of their cat said under no circumstances should a cat be vaccinated against FeLV because then they will test positive. No, that is incorrect. Okay. Whole blood for the provirus as well, and whole blood here for the point of care, and then blood or saliva for virus detection, actual virus detection. So here I'm going to take the FIV out, point of care for testing for antigen here. If they're positive, then we're going to do our level 2 diagnostics, doing PCR or like proviral PCR or referral lab microtiter if it's not already done, or IFA. If it's positive, they're infected. If it's negative, it's unclear. If they're negative, retest in 30 days. This is if somebody, for instance, I find it very difficult when somebody comes in with a cat bite, which may or may not be in fact abscessed or not at the time. And I say, we need to see them back in 6 weeks to test them, retest them. We're going to test them now and retest them for FeLV. They don't show up. So it's very helpful if you either pre-charge them for it and pre-book the next appointment. But you can, at the very least, test them at the time. But really, you should be testing them 60 or 30 days later, sorry. Okay. Now I'm not going to, this is a little too much to go through in a webinar. This is from the ABCD group. But here you can see, do they have clinical suspicion? Yes, no. If they're healthy or without clinical suspicion, this is where it gets to be, you know, are they negative? Were they at risk of exposure within the last 6 weeks? No, they're unlikely to be progressively infected. If they're positive here, retest in at least 6 weeks or more, or test for proviral, retest, etc. So you can go through this at your own pace. essentially I've been, talking about this already. So here, if you've got somebody who has a clinical suspicion of FeLV and tests negative on the point of care or ELISA, then you're going to retest immediately for proviral. If they're negative, they're unlikely. If they're positive, etc. Okay. So false positive P27 antigens at point of care. These things drive us crazy, or they should. In areas of low FeLV prevalence, positive test results may be false positives. A positive test result in a healthy cat should be confirmed, preferably by PCR. So here's the example I use. If we have a group of nuns on the one side, and we have a group of unhomed people living rough, IV drug users, the interpretation of a positive test is going to be very different. It's more likely a false positive when the individual has very low risk of being exposed, when there's a low prevalence in the environment. Whereas if you've got a high prevalence in the environment, then they're more likely a true positive. So here, and this is FIV now, please pay attention here because FeLV would be different. If you've got someone who's living has a low prevalence of exposure versus a higher prevalence of exposure, because FeLV, both of these would be there, then it's more likely to be a false positive in the multi-cat indoor, aspirationally indoor household for FIV. So we're going to repeat the test. With FIV and somebody who is living rough on the streets, it's more likely a true positive and verified with a different test. This is for FIV. So positive predictive value versus negative predictive value. If the test, what positive means is if the test is positive, what is the probability that that patient actually has the disease? So clearly it's very low in the nuns and very high in the IV drug users. Negative predictive value is if a test result is negative, what is the probability that that patient does not have the disease? So if it's negative in the IV street drug user, chances are that that cat is probably positive, meaning it has a low negative predictive value. Okay, so prevalence is super important to know, as well as a whole bunch of other things regarding reliability of the test. But just looking at the sensitivity and specificity does not tell you anywhere near enough. Okay, discordant results are due to the stage of infection at that point in time, or the prevalence and or it could be that the test was done wrong too. Cats that have cleared FeLV from plasma who are regressively infected or whole blood will be negative by P27 antigen tests, but will remain positive by PCR for provirus. And some cats may even be positive for RNA at low levels. Again, not going to go through this, but this is a very, very useful table. You just can't talk your way through useful tables. It's just too bloody boring. So take your time and look at this. For progressive, regressive, abortive, no infection, what's going on, free soluble, what you're testing for, and what your chances of what your results will be. So what do I need to know about IFA? We're not actually doing it all that much anymore, but it detects secondary viremia, where the P27 will be positive before but P27 will be positive before IFA is positive, and proviral is positive before the P27. Most regressively infected cats will test negative on IFA, and there can even be false negatives in cats with leukopenia who are FeLV positive, because what you're looking at is the reaction between dye and the antibody on a blood smear, and if there aren't very many white blood cells, then it's going to come out negative. On the other hand, you can have a false positive if there's a reaction between eosinophils and the conjugates, or the smears are too thick. Then the background fluorescence is high, or the test is prepared and interpreted by an inexperienced person. So using anticoagulated blood rather than fresh blood causes errors. So again, we want to be using fresh blood. Okay, so Dolores here, she, what stressed her out? I have no idea what stressed her out, but regressively infected cats don't shed, which is a good thing, at least based on P27. Reactivation may occur if they're immunosuppressed, and risk of reactivation decreases with time. However, the integrated provirus retains the ability to replicate for many years, and the reactivation to progressive disease may occur, therefore, many years after initial exposure. Now, at this point, because this is many years ago, that's the first time I thought, clearly there has to be something else. I didn't know it was called regressive, but I was also very puzzled by it. Regressive infection may be associated with lymphoma or bone marrow suppression, and indeed, she had severe anemia, non-regenerative anemia. And of course, she was 14 at this point when I went, and whereas previously she had not been tested every time she was sick, which again, I would do differently now. Now, another image from Julie Levy from ISCAID. I use anticoagulated whole blood. This is for shelters now, for shelter, FEL screening and follow-up. If the shelter can spend the money, this is a good way to spend the money. Use anticoagulated whole blood, do point of care, run that test. Stop here for the one and done, okay? Here you get the result. They're either positive or negative. Continue here if you want to do a follow-up protocol where you're going to do quantitative PCR on the positive will be confirmed, or the negative will tell you it's discordant. And if they're negative, repeat in 30 days if warranted. But so this is what's meant by the one and done, is you just do this one point of care and you declare them as positive or negative at that point, but you do not euthanize them. One and done testing, if you can only run one test, use EDTA whole blood on a SNAP or somebody else's combo. This was a study that was where the tests were provided by IDEX, so hence that's on this slide. Confirming a positive result, if you can only run additional test, use quantitative PCR to establish the expectations for survival. If the, sorry, that should say PCR, if the FeLV-PCR, proviral PCR is negative, then I run a different test, a microtiter test on ELISA, or ELISA as an option to confirm the presence of P27, and that cat's low positive, therefore likely has a longer life expectancy. We need to get comfortable with uncertainty. We don't like this. And I've just loved it with Regina and with Kathleen. They were just going crazy. Whereas I was laughing because I just think that biology is so amazing. And for us to assume we know it, we understand everything about anything is just ludicrous. So stop chasing the illusion of certainty. To be safe, manage the cats as if they are positive and pay attention to low positive cats. Sick cats testing positive on SNAP use the same combination of tests to characterize status or determine if a low positive is not a high positive and has developed progressive disease. Consider comorbidities. So get comfortable with uncertainty on these two images here. These are two cats from that big study that you're looking here at SNAP, doing on all these different tests, PET check, and doing PCR. And you can see in this cat, 0 month, this is like the other one I showed you. This cat's very clearly positive, there's no question. He did survive for 6.25 years after that he was enrolled in the study, and then he died. And here's another one who was a low positive rather than a high positive on PCR. Low positive, he was enrolled at 1 year. I beg your pardon, here he only lived for 4 months. Here it's, or I guess 6 months. He enrolled at 1 year. He survived till 6.5 years, and he's still alive. So here you can see positive on all of these point of care tests. He's although negative here in month 4, and then negative just on the plasma and serum in month 5, and then back to being positive. Here with the follow-up PET check, he was low positive and negative here, and then with PCR, he was low, although high here and negative there. So he survived a long time with that. Okay. So prevention of infection is through vaccination. Clearly vaccination. Here you can see different countries where what percentage of patients in clinics, obviously not cats in the country, but patients in the clinics are vaccinated. And you can here on the left, you can see the prevalence, huge difference here in the UK. Here, for instance, in Italy and Malta, less vaccination, so higher, or in Portugal, so higher higher positivity. Here, again, from the AFP guidelines, initial vaccination protocol is recommended. Administer the FeLV vaccination series to all cats at risk and all kittens up to and including 1 year of age. Test all cats for retrovirus infections regardless of age before vaccination. Give vaccination as early as 8 weeks of age. Give them 2 vaccines 3 to 4 weeks apart. Give them the booster vaccine 1 year after the initial series. And then we revaccinate for cats 2 years of age and older. Don't revaccinate if they have no risk of exposure, such as cats living in a single cat household, no exposure to other cats, household with other cats known to be negative, whatever known means, cats with outdoor exposure to enclosure only or no outdoor access, cats with no exposure to either FeLV infected cats or cats of unknown FeLV status. Revaccinate annually if they're at high risk, such as cats with outdoor access, living with known positive cats, or in contact with cats of unknown status. Revaccinate every 2 years cats with low risk of exposure, such as cats with no history of intercat aggression, example, previous cat fight bites, and cats with limited outdoor and low possibility of exposure to cats of unknown FeLV status. So you need to know really everybody in the household what's going on with them. Okay, so vaccination, just to reiterate, against FeLV does not diminish the importance of testing to identify and segregate cats with progressive FeLV. Now, is it safe to vaccinate a regressively infected cat? Absolutely. But antigen test them first, because if a vaccinated cat's status is unknown and he or she is later found to have a progressive infection, vaccine efficacy would be questioned and vaccine failure suspected, and you get a grumpy person. Unnecessary vaccination also causes the risk of potential adverse reactions. So what about efficacy of vaccines? What do we know? Well, unvaccinated cats with bite wounds were 7.5 times more likely to be infected than vaccinated cats, suggesting protection. These were adult, than infected and vaccinated cats. It's difficult, however, to assess vaccine efficacy. And I alluded to this earlier on too. Not only are the studies small and they're conducted in research cats in general, except for that Austin Live, whatever it's called, study. The studies were performed or supported by vaccine manufacturers in many cases. There's a lack of standard challenge and testing protocols. As I said before, my goodness, when we look at prevalence across countries, what are we even testing for? So, and it's difficult to infect control groups of adult cats without inducing immune suppression. Now, way back, Andy Sparks published a paper in 1997, and then he updated it in 2003. And here you can see across, and these were the vaccines that in the form they were at that time, which is what they'd still be licensed as now. And some of these vaccines don't exist anymore, unfortunately. But here you can see how small the groups are that have been studied, how many controls, no controls here at all, like you gotta be kidding me. And then the preventable fraction. Remember, preventable fraction is the number of cats who were vaccinated and exposed who did not get infected relative to the number of cats who weren't vaccinated and did get infected. So again, some variables there too, and it's really all over the mark. Like what this means, I have no idea, but this vaccine's long gone. So it's all over the place. And so it's really, the vaccines are of a number of types. They're either inactivated or the recombinant vectored or RNA particle. These are the 3 types we have. canary pox vectored vaccines are non-adjuvanted and have been associated with a reduced risk of injection site sarcomas. That's a recombinant vectored. One study suggested that the degree of protection induced by the recombinant canary pox FeLV vaccine may not be as robust as that induced by a whole inactivated FeLV vaccine. So that's where you've got inactivated and adjuvanted, which might produce sterilizing immunity, that the whole inactivated might produce sterilizing immunity. So, however, moderate to severe immunosuppression may have impacted those results. So further studies are required to determine whether a clinically important difference actually exists. So is there anything more current? Well, in September of 2024, Merck produced received licensing from a license from the USDA for Novavax NXT FeLV. And the safety and efficacy data is available from the USDA or from Merck. But what the USDA says too is that vaccines licensed to, and this is across any vaccine, this is not just for this vaccine, please understand that. Vaccines licensed to protect against the same pathogen should not be assumed as equivalent. So we still, don't know. And while I really, really love the platform that these vaccines are being made, the next platform, Novavax platform, is fantastic. So please do check out the 2020 AHA AFP feline vaccination guidelines as well. Vaccination caveats are, we cannot conclude that FeLV vaccination protects against all outcomes of infection. Nevertheless, several, but not all, current vaccines appear to be efficacious at preventing progressive infection, thereby curtailing FeLV-associated disease. Duration of immunity of FeLV vaccines is at least 12 months, and this was prior to the Novavax next FeLV coming out. This was 2020. The vaccination visit should always include a comprehensive physical exam and conversation so that the caregiver understands how clinical staff assess disease risk and offer recommendations that help support human cat relationship. No vaccine is perfect, especially in a high pressure situation. So with the remaining 6 minutes that I've got here, and please stick around for questions, we'll look at housing and managing transmission. So where possible, FeLV, in the home, FeLV infected cats should be housed in stable, low density environments where stressors are reduced with ample resources and where they should be living together. So you should have FeLV positive households. Ideally, they should be indoors when it's behaviorally acceptable to the cat. And similarly, if you've got some buddies and where one of them is positive, but the others are negative, but they love each other, taking them apart would be problematic. Just make sure you vaccinate those negative cats so that they don't become positive for the others, and neuter all cats. In a multi-cat household with infected cats, if there's a progressively infected cat living in a negative household, most of the other cats have already been infected and are most likely immune to new infections. So they're either regressive or have aborted it. The risk of reoccurrence of antigenemia in an adult, is 10 to 15% in a stable household with one or more progressively infected cats. And this is probably from reactivation of their own regressive infection. If the caregivers refuse to separate them, vaccinate all uninfecteds, as I've said, and inform caregivers that vaccination is not a guarantee. So in the AAFP guidelines, there's a whole bunch of sections on considerations for multi-cat environments, breeding catteries, and cats in shelters for both FeLV and FIV. Few points though about shelters. Cats should not be euthanized solely based on the retroviral status. All cats entering shelters should be considered potentially retrovirus infected. If there aren't many resources, test sick cats and cats with bite wounds or abscesses and hoarding cases. Because there's a lot of stress in long-term institutionalization, transition quickly to foster or adopt. FeLV cats should be adopted out to homes as only cats or those with other FeLV positive cats. test the cats going in, the other cats that are already at home. Retrovirus positive cats should be housed together, so FeLV with FeLV or FIV with FIV. Vaccination against FeLV is not needed unless they're group housed. The presence of infection can vary. So test, if you're not going to test and vaccinate, then at least test. The presence of infection can vary within individual litters, so don't conserve costs by testing one cat as a proxy for others because it's unreliable and it's a poor use of resources. Don't group house untested cats, and there's one and done, as I've mentioned, with a reliable screening test will identify most infected cats. How do we manage the individual? The infected individual, vaccinate routinely, except for FeLV, even if indoor only. So if you've got an FeLV positive cat, they may not be able to mount an adequate immune response, so that protection is not comparable to that in a healthy cat. More frequent vaccination, example yearly, could be considered rather than every 3 years for FERCP. If FeLV infected cats are sick, identify the secondary illness promptly to treat urgently, and a longer and more aggressive course of therapy might be needed. Avoid corticosteroids and other immunosuppressive or bone marrow suppressive drugs unless you have a clear indication. Remember, core vaccines are those which protect against pathogens that cause severe disease, are highly contagious, lack good treatments, or have zoonotic risk. And therefore, FERCP, rabies, and FeLV up to and including year 1 boosters are considered core. If you've got somebody who's positive, preventively examine them every 6 months to detect early changes, including oral health. Make sure they're receiving internal and external parasite control. Vaccinate based on the risk assessment, but not FeLV. Make sure they're getting good nutrition. Monitor body and muscle condition scores and weight trends. Avoid raw foods, please. Perform a CBC every 6 months. Once a year biochemistries and a UA, and spay and castrate them. Management of critical illness, and manage critical illness and treat secondary diseases. Manage clinical illness and treat secondary diseases if the illness is unrelated to retrovirus infection. Manage as you would any other cat. Retrovirus infected cats with severe gingival stomatitis are most likely to benefit long-term from full mouth extraction with complete extraction of all tooth roots rather than medical management. But that's, we do have some newer information on that too now. So establishing the cause of clinical signs, if in retrovirus infected cats, if unrelated to the retrovirus infection, these include diseases and illnesses common to cats, lower urinary tract, etc. Secondary to retrovirus infections, I've already talked about that, diseases, infectious diseases, neoplasia, chronic gingival stomatitis, directly related to retrovirus if we're looking at FeLV, neoplasia, bone marrow suppression, neurologic disease. With persistent fever, we really want to look for concurrent viral, protozoal, or fungal infections because FeLV on its own does not cause fever. So cautions with respect to treatments, I've already mentioned glucocorticoids and immunosuppressive drugs, unless you've got an FeLV-associated immune-mediated condition. These agents impair granulocyte function and increase risk of secondary infections. In regressive FeLV cases, glucocorticoids could trigger viral reactivation, so proviral PCR. Also avoid myelosuppressive drugs. Now, in the hospital, how do we limit transmission? Well, they're pretty darn unstable and there's a low risk of transmission. They're readily activated by routine detergents and disinfectants on dry surfaces, but in the poop, for instance, if the poop's wet, it may continue to be there. So make sure you keep those boxes meticulous. Don't allow FeLV positive cats to have direct contact with other cats, but don't isolate them because isolation has got bad things that these guys may not be able to fight off, including some canine diseases like panleukopenia. So treatment of, whoops, sorry, that's a dupe there. I'm going backwards, that's why. FeLV virus being enveloped doesn't survive for long. may survive in feces, but also if anything else that's kept wet, contaminated needles, refrigerated blood for transfusions. So the ideal donor selection, don't have time to talk about that, but that's in another paper that I have, the resources, which I'll show you at the end, have also been sent to, Karen Prost, and she can provide them to you if you wish, including here one on collection and administration of blood and blood products in cats. But here you can see FeLV antigen and FIV antibody testing. Negative can be done in clinic, and FeLV, you need to do a provirus test as well. Retrovirus are easily transmitted by contaminated body fluids, especially blood, dental surgical instruments, endotracheal tubes, suture, if anybody's reusing it still, IV fluid lines and bags, food, reused hypodermic needles, oral dosing devices. So be thinking about that when you're reusing for assisted feeding, oral feeding, and the like. Wash hands between handling every patient. We should be doing that anyways. All blood and tissue donors must be screened. Surgical care and perioperative care. Perform surgery as needed in otherwise healthy cats. Healthy FeLV cats, same preoperative evaluation and lab testing, same everything else. Use perioperative antibiotics only when there is clear evidence of immunosuppression or if surgical risk of bacterial contamination is likely. Use multimodal analgesia as indicated, especially if there's concurrent painful conditions. Targeted therapies, squat. Okay, drugs are available to treat retrovirus infected cats. They're limited, tend to show lower efficacy in feline compared to humans. AZT can be used. It can reduce viral load. Here's the dose. In FeLV infected cats, the higher dose may result in adverse effects, non-regenerative anemia. Published studies using oral feline interferon omega in FeLV or FIV infected cats are lacking. So there's still pretty much hearsay. Here's a whole lot of stuff on that you can check on your own. There's 3 more slides here. Hang with me. Role of stress. Avoid isolation wards, ideally segregate and keep indoors. Low density environment reduces risks of co-infection, but not if it's stressful for them. It might be less stressful to allow retrovirus infected cats access to the outside within a catio or something. Cats who do not exhibit high-risk behaviors, breeding, reproduction, fighting, pose little risk of transmission of disease. Adoption from reduced stress within homes by meeting all environmental needs, neutering all cats, adopt from a shelter into a home-like setting, reduces stress, and is likely to result in better long-term outcomes. Nutrition, super important. Proteins make all the immunoglobulins, be it hemoglobin, be it antibodies, be it muscle, not muscle, immunoglobulins, but proteins are needed for that. Feed a nutritionally balanced and complete diet appropriate to the cat's life stage or health condition. Avoid raw meat and raw dairy products. Perform nutritional assessments periodically, and unexpected downward trends in body weight or reductions in body and muscle condition score are reasons to investigate further. Can I responsibly adopt out a cat who is confirmed positive? Yes, you can. These are the caveats: neuter all cats, low population density, etc., and vaccinate if they're living with other cats. Vaccinate them against FeLV. So the key points were with prevalence. It's social cats and cats under 1 year. Outcomes of exposure: abortive, regressive, progressive, and regressive can become progressive and backwards potentially. Decreased life expectancy in progressive and in high positive regressive types of illness. I've talked about that. Diagnosis: get comfortable with uncertainty. And we've talked about the one and done test for large populations. Prevention of infection tests: separate, vaccinate, do not euthanize. The husbandry needs: limiting transmission in the home in multi-cat environments, point of care and PCR all donors. Vaccinate infected cats against everything other than FeLV. Manage for clinical illness, look for other diseases, cats with dental diseases, more frequent checkups. So is FeLV seeing you without you seeing it? Probably. Because we're seeing here how many of those healthy cats are in fact FeLV positive. Now, resources, and I do apologize for going this much over time. It's horrific. I've got QR codes in here. You can also look at the, you can also ask Karen for these. And there's the DOI on the retrovirus guidelines. I don't know why I don't have a DOI in for the others. They may not exist because they're fact sheets. And then the AHA AFP vaccination guidelines, consensus guidelines on blood collection, and then some lovely FeLV case challenges. So with that, I thank you, and I would love to take questions up the walls, but I will ask Janie, who has been very kind in hosting this, and Karen, what we have time to do.
All right, thank you. Well, since we are well over the hour, some have asked questions in the chat. So unless you think the answers are more on the longer side, we can actually get those to you directly, and you can potentially just reply to those questions personally.
Okay.
Would you be okay with that?
There are, I think, only two here. So
correct.
Yeah, so let's just quickly do those. Where does testing the bone marrow for FeLV come into play to rule out FeLV as a cause for neutropenia and non-regenerative anemia when other FeLV tests are negative and bone marrow fibrosis, immune-mediated disease, or lymphoma is not evident? I would still, I mean, if you've got proviral negative, you're and antigen negative, it's very unlikely that you need to do an IFA. Then if owners decline testing, are there health drawbacks to vaccinating a potentially positive cats with FeLV vaccine? No more than giving any unnecessary vaccine for anything else, but health drawback. I'm glad to clarify. Thank you. I think those are the only questions there, and you'll get those, resources. Yeah, hey, Sue, how are you? I can definitely pop those up again, but so you there we go, share, and I can give you, sorry, let me get back.
While you're doing that, Dr. Scherk, thank you. Dr. Scherk has shared some amazing resources, the ones that are currently up on the screen. Just so you know, you will also be sent some of these references in an email. Everybody joining, thank you, and a wonderful day, everyone.
Thank you. Take care, everybody.
Thank you, everyone, for attending today's session.